All right, hopefully you guys can see my screen.
So the Friday before break, we left an open question that came from our understanding that for a reaction to be product favored, we had this idea that there's a free energy change that's negative. So we introduced the idea of delta G. We noted that it's equal to minus T if this is a system property. Delta S of the universe. The second law of thermodynamics says that for anything that happens, this number is positive. And if that number is positive, temperature's in Kelvin, that's a negative sign, so this number is going to be negative. And so either delta S of the universe positive or delta G of the system negative is just a thermodynamic predictor of whether...
April Fools. I just wanted to punk you guys. Because I think everybody is far too serious. And it's been a long time since you guys have had a thermodynamic, so I thought I would screw you a little bit. Y'all were a little bit freaked out for a second, huh? You're like, wait, we were supposed to talk about immune-related adverse events. What's happening? All right. Now that we've had that here. You're waiting for entropy. I like it. Okay. All right, so actually now we will do real class here. Okay, so let me pull this up again because of course now in order to do the joke, I lost my screen. It was worth it though. All right, okay, coolio. I thought you guys would enjoy that. I see some smiles, that's good. Okay. All right, so are you guys actually able to see my screen for real this time?
Yes.
Yes, okay. You're like, we hate her now. She stressed us out for like good, I love you guys too. All right, so basically before I start the iRat today, just really quickly, so the guidelines for immune-related adverse events are pretty voluminous and they're also evolving. So I'm not expecting you guys to know like nitty-gritty details necessarily. This is more of just trying to get you comfortable with how we make decisions when we're treating patients who are having complications, in part because it's not like chemotherapy where we just can reduce a dose or potentially change, change therapy. So you'll kind of start to see a pattern emerge kind of as we go through this. And if anybody has any questions, let me know. So when giving a patient prednisone for an IRAE, you should discontinue the prednisone as soon as the patient's, sorry, I forgot an apostrophe, symptoms have resolved to prevent steroid-related complications. Is this true or false?
False.
False, because you need to taper it.
That's right. Why do you need to taper it?
To avoid rebound effect.
Exactly. So, traditionally we taper, especially high dose prednisone, when someone's been on it for, 60 milligrams or equivalent for more than a couple weeks because we worry about having adrenal insufficiency. But in this case, the reason why we taper slowly is for that exact reason. Once you tamp down the immune system, if you pull back the steroids too quickly, you could end up having really significant rebound effects. And for patients who have colitis or, maybe a neuropathy or some other significant problem, we don't want to do that because we can really make patients much worse. Okay, good job. So you have a 32-year-old, no, okay. You have a 32-year-old cisgendered female receiving durvalumab for stage 3 lung cancer. And we'll get to that when we get to lung cancer. Your patient is interested in getting pregnant. What advice should you give her? So which one of these do you think makes sense? And this is a common issue, especially with younger patients. Yes, Poonam, I think
for 5 months.
Go ahead. That's right. Yeah. So we want to use contraception or encourage it during and for at least 5 months after discontinuing therapy before conceiving. Now, question for you guys, and I don't know if I've necessarily covered this, but how many forms of contraception do you think females need who are of childbearing age when they receive any kind of anti-neoplastic therapy?
3.
Well, I think probably just 2, but that was a good guess.
The male side.
Well, yes, right, exactly. So their male partner needs to wear a condom, so they have to have a barrier method, right? And also, the female needs to use some form of ovarian suppression. So, whether we're giving them an injection or they're using some sort of oral contraception. And again, that's really the safest thing for a patient, because we know that birth control is not necessarily 100% effective. And then for patients who are receiving chemotherapy, their immune systems are, much more fragile. And so using a barrier method is also helpful to prevent infection. All right, perfect. While the potential fetal harm is not really well known or defined, because generally speaking, people who are on therapy in clinical trials don't get pregnant because they are required to use different forms of contraception, we still really don't know how this could potentially affect fetal development. So it's kind of the safest thing is to say, assume that it has extreme risk and to avoid it altogether. Okay, so this one might be a little bit more complicated, but during therapy with an immune checkpoint inhibitor, which of the following labs do you want to periodically assess in your patients? So of the lab options available, what do you think is probably the most prudent? So what's that?
The last one?
That's right. Can you talk me through a little bit about why?
For TSH, we want to see if the patients have hypothyroid or hyper. Same thing with the T4 for the thyroid. And then we want to check to see if for the LFTs, we want to see if they have any like GI symptom like hepatitis, and then glucose for diabetes. And the CBC with DIF, we want to see if the patients have any infections.
Mm-hmm. Right, exactly. And then another piece of that CBC with DIF that we're concerned about is that even though it's unusual, these immune checkpoint inhibitors can actually cause hematological toxicities. It's not extremely common, but it does give us a kind of a baseline, and it allows us to kind of watch in case patients all of a sudden have a major drop in platelets, for example, or a major drop in white count, or a major increase in white count. Because another thing that happens when patients are developing, hepatitis or some other autoimmune related event, it's not unusual for them to have a sky high white blood cell count. And that often can be an indicator that something is getting ready to happen, especially in patients who maybe don't really have significant symptoms. So this is really important. Now, for a couple of the other drugs, so for the most part, the anti-CTLA-4, like ipilimumab, and the PD-1s and the anti-PD-L1s, they have very similar side effect profiles, except that the anti-PD-L1s, like durvalumab and atezolizumab, seem to have a higher risk of pancreatitis. And so for them, we usually will add in like an amylase as well. But those are really more agent specific. So for our purposes, I just want you to know that in general, when you've got a patient who's either beginning on a checkpoint inhibitor or is receiving therapy, you want to be checking these labs fairly frequently, because they can change, really at any time, because we know that side effects can happen anytime. Any questions so far? All right. So patients receiving, well, I added another checkpoint. Yesterday was a rough day. So patients receiving immune checkpoint inhibitors can experience which of the following IRAEs? Select all that apply. So as a group, what about enterocolitis? Can that happen? Yes.
Yes.
What about pneumonitis?
Yes.
Yep. What about cytokine release syndrome?
Yeah.
Yes.
What is cytokine release syndrome? Do you guys know? It's okay if you don't, or if you just want to kind of hypothesize what it is. So the name kind of gives it away. So what is what's that?
Cytokine storm, where it just releases everything. You just have severe reactions to just in general.
Exactly. So it's considered a non-IgE mediated reaction. And what happens is you get a pretty substantial release of a lot of inflammatory cytokines all at once, just like you said. So tumor necrosis factor alpha, IL-1, IL-6, interferon gamma. And that allows for the recruitment of T cells, but it also it wreaks havoc on a patient. And it's essentially like having an anaphylactoid reaction as opposed to an anaphylaxis reaction. So we'll talk more about that when we talk about oncological emergencies, but it really is very much related to, some of the serious reactions that happen with like CAR T cell therapy, which we'll talk about in a little bit. We'll talk more about this. What about neuropathies like myasthenia gravis and Guillain-Barré? Is that something that can happen as an IRAE? Yeah, I see somebody nodding after gauging my reaction. Okay, so what kinds of other things can happen to the brain and the central nervous system from these drugs? Any takers?
You can get meningitis, encephalitis, ataxia, aphasia.
Yep, that's right.
Peripheral neuropathy.
That's right, exactly. Now, I will tell you the strangest neurological sign and symptom I ever have seen thus far in a patient receiving a checkpoint inhibitor. I had this one patient who had melanoma, and she was receiving nivolumab, and she came into clinic like the next day after her like third or fourth infusion, and she literally could not open her eyes. Like her eyelids were just kind of frozen in place. And so, we were really perplexed, and it was when we had just started infusing quite a bit of nivolumab, and really it looked like it was very safe because we weren't having very many reactions or problems. And we ended up actually having to send her to a plastic surgeon to have the plastic surgeon do some kind of an eye lift so that she could open her eyes fully again. Really crazy. So any kind of side effect that you can imagine can actually happen with these drugs. And one of the reasons I added this in is because if you have a patient who's on a checkpoint inhibitor and they start exhibiting weird symptoms, it's likely that it's caused by the checkpoint inhibitor. So a lot of oncologists will like to blame everything on chemotherapy. Chemotherapy has pretty defined types of adverse events. Sometimes we'll get something weird happen, but for the most part, it's pretty obvious what's going to happen to a patient. But with the checkpoint inhibitors, it's not. So I had another example. I had a patient who had psoriasis when she was in her 20s, went into full remission, had no problems. We started her on Keytruda or pembrolizumab. And within about, I think it was like 6 or 7 months, all of a sudden, one morning she woke up and she had psoriasis literally all over her body. So again, anyone who's also previously had or has an autoimmune condition, when you start them on these therapies, you have to expect that it's likely that it will come back in full force or that they'll have some other kind of event. One of the other things that's interesting about checkpoint inhibitors is once someone has had one kind of IRAE, they are much more likely to have another kind happen. So say, for example, you had somebody who had like grade 1 colitis. No big deal, it resolved, and you were able to keep them on the checkpoint inhibitor. And then it's not uncommon for a few months later, bam, to have something else like a severe rash or pneumonitis or diabetes or any of these other things that can happen. Hepatitis is really common too. So again, I want you to also be thinking of if someone comes in for treatment or starting off treatment who has an autoimmune disorder, you need to be very concerned that this could cause a problem. And if something happens, to patient once, it's likely that something else will happen throughout treatment. And that's really one of the reasons why often we'll discontinue therapy completely if someone has a significant enough reaction. Cool. And then type 1 diabetes, that can happen too, right? Exactly. So pancreatitis and type 1 diabetes, they're not extremely common. In fact, I would say they're more common with the PD-L1 inhibitors like durvalumab, atezolizumab, but it can still happen at any point with these drugs. Any questions about this? If you can imagine it, it can be a side effect. That's sort of the takeaway point, which is scary for patients because I can't really tell them what they're going to experience during the course of their therapy. Okay, so flat dosing strategies for checkpoint inhibitors are beneficial for which of the following reasons? So which of these make sense?
Reduced risk of dosing errors.
Exactly. So we know that that's not the case for, these agents actually have a fairly broad therapeutic index, right? Which is why we're able to do flat-based dosing instead of weight-based. It makes it a lot easier to compound in the pharmacy, which also helps to reduce the risk of errors because you're not having to calculate, anything unusual. And then it decreases waste. Well, they say it decreases waste, but what I can tell you is that for people who are, overweight or slightly bigger, then yes, you may be potentially saving quite a bit of money because you're not having to give them much bigger doses. But for people who are small framed or, or closer to their lean body weight or whatever it is, if they're slender, you actually end up wasting a lot of drug. So the flat-based dosing, even though it sounds great, was pretty controversial for quite a while because people were like, well, but wait a second, I'm actually throwing away more drug now. So kind of depends on who you talk to, but anytime we can reduce risk of errors and individual calculations for patients, that's the best possible thing. All right, so for number 6, so what's ipilimumab? What's its mechanism of action?
CTLA-4 inhibitor.
Exactly. And then what's atezolizumab?
PD-L1 inhibitor.
L1 inhibitor.
Perfect. And what about durvalumab?
Okay.
PD-L1.
Yep. And what about nivolumab?
PD-1.
Awesome. All right. So patients are not likely to have immune-related complications after cessation of checkpoint inhibitor. Is that true or false?
False.
That's right. And why is that false? So once we stop giving the drug, like with chemo, for example, right, people tend to not have any more side effects once they kind of recover and the drug has cleared their system. But these drugs don't work like that. They work by waking up the immune system. And once that beast is woken up, it can kind of overreact at any point. So, the median onset for some of these different side effects, for example, like increased serum creatinine, hepatitis, colitis, can vary with a single agent therapy between like 4 to 8 weeks, kind of median time to onset. Again, it depends. It could be 12. But then what we also see is kind of like this bimodal curve where you'll kind of have a peak around between that like maybe 6 to 12 week period of time. But then we have patients on trials who start experiencing problems a year or even 2 years after they've stopped therapy. So one of the things that's really important is when you're talking to patients and they're like, yay, I'm done with therapy, like my doctor decided to take me off, or my doctor decided to take me off because I'm having this side effect. You need to make sure the patient knows that at any point after for the next year or two, it's possible for this to reoccur, either the same issue or a different one, which again makes it kind of hard for patients because they're like, well, wait, I stopped this, so I shouldn't have any more problems. So it's important to communicate. Any questions about that? Awesome.
I was just kind of curious about if they've explored like low dose corticosteroid to help prevent that, or if there's anything.
So that's a great question, actually. Unfortunately, there is a concern that low dose corticosteroids will attenuate T cell response and activation. So one of the requirements for the studies, for example, like the Keynote trials, which are for pembrolizumab, or the checkpoint trials for nivolumab, which are still kind of ongoing, and they're just doing them different combinations. They don't allow people on the study if they're taking 10 milligrams or more daily equivalents of prednisone. And they in part do that because they're concerned that, again, it'll diminish response. Even for example, a cytokine release syndrome in CAR T cell therapy, for a long time, people were afraid to give high dose steroids to attenuate the response because, again, they were afraid it would damage efficacy. We know now that that's not true. It's the same reason why we're still able to give dexamethasone, for example, for a few days to prevent nausea and vomiting when patients have one of these therapies combined with carboplatin, for example, or some of the other combinations that exist. So, I think at some point it might be studied, but because there's a concern that it would diminish efficacy, there may be an ethical issue with having starting a study like that.
Right.
Cool. Okay. So your patient has begun treatment with ipilimumab for metastatic melanoma. Approximately 2 weeks after beginning therapy, he develops diarrhea with 4 stools above baseline. He's due to begin his next cycle tomorrow. What is the correct course of action for your patient?
C.
That's right. Can you talk me through a little bit about why that makes sense?
So with the with the number of stools, the bowel movements that he's having, that's a grade 2, and so it would be imperative to start prednisone 1 mg per kg per day, and then you would hold it, and then you could consider discontinuing if there's no improvement.
Right. And so I don't know if you remember this, but if the drug instead were nivolumab or pembrolizumab or atezolizumab, one of the anti-PD-1, PD-L1s, would you automatically permanently discontinue it? Would you consider that for grade 2?
If they're a CTLA-4 inhibitor, yeah.
Right. So if it's a CTLA-4 inhibitor, but if it's a PD-L1 or PD-1, probably not.
Oh, yeah, you would just hold it until they reduce down to like a grade 1.
Exactly. Perfect. Now, the reason why there's a difference, right, is because ipilimumab, when it first was being studied, and even since then, it can cause fatal enterocolitis pretty quickly. I actually did have a patient pass away from enterocolitis related ipilimumab, one of the first times we started using it. So it is a drug that you need to be very careful as soon as patients start exhibiting signs of enterocolitis. Now, where the gray area comes in is, let's say, for example, I did this and I discontinued it, but the patient still needs therapy, right? Would it be safe for me to try nivolumab or pembrolizumab? And the answer is we're not really sure. It might be, if the patient had been really responding well to the ipilimumab and they're otherwise healthy and this is not really like salvage therapy, then I might be willing to take the risk and start them on that once they've resolved to a grade 1 or below. The problem, though, is that, as I've said before, once you've had one IRAE, you're likely to have another, or potentially have this one come back and be much worse. So again, this is where kind of gray area comes into play, and you have to really base it on patient-specific goals, How severe was the, diarrhea? Is it worth the risk? So any questions about this?
Is there a correlation with the PD-1s, PD-L1s, and the CTLA-4 with the differences in changing? Or is it just kind of just across the board, they just accepted that you're more likely to have something happen?
It is across the board. Yep. And then the risk increases dramatically when you combine the two agents, right? So we don't combine like two anti-PD-1s or anti-PD-L1s, but we do combine, in many instances, a CTLA-4, and the only one in the market currently approved is ipilimumab. There's another one called tremelimumab, or Tremi, and that one's being studied, but so far some of the studies haven't really yielded the same kinds of benefit that ipilimumab has shown. So yeah, unfortunately, it's just across the board. But I will say that the anti-CTLA-4 inhibitors in general seem to cause worse side effects more quickly than some of the other ones. Cool. All right. Moving on. So for a patient experiencing grade 3 pulmonary toxicity from an ICP, please select the appropriate treatment. So which one of these is reasonable? And why? I see Karen smiling. I could tell she's about to talk.
No.
Yes. No.
Oh,
Go ahead.
I ended up putting a start methylprednisolone 2 mg per kg and then add infliximab with no improvement.
Mm-hmm.
So because it's grade 3, and I know it said consider antibiotics, but that's if we're suspecting an infection, and based on this statement, that's why I didn't do the antibiotics and mycophenolate, because that said infliximab, mycophenolate, or cyclophosphamide if there is no improvement within 48 hours.
Exactly. And so why would you pick methylprednisolone as opposed to prednisone, for example? So why was this one better than this one? I'll make this easier for you. What available routes are there for prednisone? How do we give prednisone?
You can give it PO, but you could also give it IV. But methylprednisolone we can give IV.
Mm-hmm. Exactly. So
you probably want something faster acting for the patient.
Exactly right. So prednisone IV, I've not really ever had access to that. I don't know specifically that it is formulated like that. It's possible, but generally speaking, we associated it with like PO only. And in this case, right, with a grade 3 reaction, you're absolutely right. We need to give something IV right away. And then because I've explained before that pneumonitis, can progress really quickly, we would probably have a low threshold for adding infliximab. Although, and one of the things that we're going to do with our application today, and it's a longer application, so I'm really just going to let you guys have some time with it. This is going to be something we'll work on, because I thought since you're getting ready to start your appies, and yes, I promise they will start when all of this is over, it'll be fine. But it's good for you to have the practice of trying to tease out, well, why would we use infliximab? Because it makes sense to use it for colitis, right? I mean, we use it for Crohn's. We use it for arthritis. We use it for psoriasis. I mean, there are a lot of other indications that infliximab can be used for, kind of like Rituxan. It's like the kitchen sink, Oh, you got a little bit of ITP? Let me give you a little bit of Rituxan. So, I think this will be interesting for you guys to really look and see what the evidence says specifically about infliximab with pneumonitis. So you're absolutely right. Now, we could, in addition, give empirical antibiotics, and then we could try mycophenolate if the infliximab didn't work. But this is more adjunct therapy. This is like, we're really trying to give like a first-line therapy for a patient. Now, one of the other things to consider about pneumonitis is that because your airflow, your alveoli and everything fill up with fluid, and you have an increased mucus production, your cilia start to slow down, right? So they're not beating as well. It is likely to develop a pneumonia from the lack of air movement. So it's pretty common that we'll give empiric antibiotics also for patients to help prevent them from developing a hospital-acquired pneumonia, especially if they're going to be there for a long time, or if they're ventilated as well, which hopefully you're not. But when we get to grade 3, grade 4, especially like kind of later grade 3, it's more than likely that you're going to be intubated. All right. Any questions with that? And great job, Karen. Thank you. Okay, so your patient has received 3 cycles of Opdivo and has a TSH of 1.2. The patient has some heat intolerance but is otherwise complaint-free. What is the appropriate course of action? Does anyone want to take this one on? This is gray too. Come on. I know somebody wants to take this. Anybody? Don't make me call on you. I can see all of your faces. Well, not all of your faces, so I might call on someone who doesn't have their video on.
I thought it was Alfredo and reevaluate in 2 weeks.
Exactly. That's exactly right. So why are you encouraging us to do that? Or at least what part of this statement about the patient makes you
Low thyroid.
Yeah, so the patient is basically having evidence of hyperthyroidism, right? They have some heat intolerance, so that means they probably have a little bit of discomfort. But I didn't mention anything about like heart palpitations or weight loss, or extreme fatigue, things like that. So in this instance, and if you remember from the recorded lecture, hyperthyroidism basically happens, hyper and hypothyroidism occur in every patient, right? So usually what happens is you get this weird burn where the immune system gets activated and you have basically like a brief period of almost like Graves' disease, right? Where your body is attacking your thyroid and your thyroid is hyperactive. Now, most patients have very little symptomatology or like no evidence except on labs that this is happening. What'll happen is the thyroid then burns itself out and then it drops. And that drop is usually where we have to start giving patients Synthroid and do the thyroid replacement. And then they're hypothyroid for the rest of their lives. It doesn't ever reverse. The time where I would intervene with a patient who has a very low TSH is if they start having symptoms that are significant, then I would probably give them like propranolol and some other things to allow them to get through the symptoms to allow their thyroid to burn out. Very rarely do we ever hold these drugs unless someone is so symptomatic that I'm worried that, they're going to decompensate. But in general, this is basically an expected reaction. And I don't need to give them methimazole. That's hard to tolerate. Most people vomit it up. It's just going to go away on its own. Does that make sense? Kind of weird, right? The thyroid is really the only indication or the only reason why we don't ever hold or very rarely hold the checkpoint inhibitors. For all the other itises, we might, especially depending on the grade, but not for the thyroid generally. Does that make sense? Rock on. Okay. Do you guys have any questions before we break you out into your groups?
Dr. Leva?
Yes.
So for question 10, are we saying it's a grade 1 or a grade 2?
Well, to be honest with you, we don't really, you can grade hyperthyroidism, but for this, I would consider this to be a grade 1. Yeah.
Thank you.
And yeah, no problem. Great question. Anything else before we attempt to do the impossible? And Dr. Fox will resume host and break you out into your rooms. All right, awesome. This is kind of a fun topic, right? It's interesting. I think so, but I'm likely to think that every day. So, all right, cool. I will break you guys out, or actually, I'm going to hand the host over to Dr. Fox. And